Hello, I'm Dr. Lynda Young, and welcome to Health Matters, a show produced by Worcester District Medical Society. Today I have with me Dr. I'm going to make sure I get his name right, Alvaro Alonso. He's an assistant professor of medicine at the University of Massachusetts Medical School and UMass Memorial Medical Center. Dr. Alonso, and I'm going to use some very big words here, but we are going to define them after I'm done. So Dr. Alonso is an interventional cardiovascular specialist with a particular interest in structural heart disease, vascular medicine, and endovascular intervention. After graduating from Mexico City's Universidad Panamericana, say that right? Is that right?
Close enough.
Close, okay. School of Medicine. He completed all of his postgraduate training in Massachusetts at Tufts Medical Center, at UMass Memorial, and Tufts St. Elizabeth's Medical Center. He's board certified in vascular medicine, endovascular interventions, interventional cardiology, and cardiology. It's a lot of boards to have to pass. So just so you know, we have a very well-qualified person with us today. So welcome, Dr.
Thank you so much for Dr. Young for the opportunity to be here.
Great. Yeah. So, Dr. Alonso, I'm going to go back to those big, long words.
Yeah.
So the first one I had said was interventional cardiovascular specialist.
Yeah.
What is that?
So what is that? So what it means is that I am a heart and blood vessel or vascular disease specialist. And I am able to do certain procedures to alleviate different problems that affect the heart or the blood vessels. I don't do surgeries. I'm not a surgeon, but I can do procedures with catheters, with small tubes that are minimally invasive.
Okay, we're going to talk a little bit about that when we talk about treatment and that sort of thing.
Absolutely.
So the next thing that I had mentioned, I have to look at my notes, but the next thing that we had mentioned was structural heart disease. And I think you and I were talking about this beforehand. So can you tell us what's structural heart disease?
Yeah, so in addition to my main focus is really the vascular medicine and the endovascular procedures, related to their heart or the blood vessels. Structural heart disease is definitely something that we also do and is many times linked. Essentially refers to disorders where the actual scaffolding of the heart may be affected. For example, if you have a hole between the chambers of the heart, or if you have other, problems with certain heart valves or things. But now these days we can do a lot of things. Minimally invasive surgeries or procedures, if you may say, that can solve these issues in the patients that need them. So that's what it means, yeah.
Okay, so vascular is the blood vessels, basically. So you have a particular interest in thromboses, deep vein thromboses, and that sort of thing. Can you explain those words, number one, and then what can you do about them?
Yeah, so let me try. So I think our main focus of the talk would be to talk about the thrombosis or the blood clots that occur in the veins. If you remember, we have two types of blood vessels or tubes, right? We have the vessels that take the blood that has toxins and little amounts of oxygen. That is the blue blood in the diagrams that you see. Those are called veins, and the veins drain the blood, from the body and go to the heart. Then from the heart, they go to the lungs where they get oxygenated. They capture oxygen, and they become the red blood that you see in the diagrams. And so that red blood then goes to the heart and then to the rest of the body to deliver oxygen and nutrition, to the rest of your body. So blood clots are disorders essentially where your blood becomes clotted, just like when you cut yourself and you form a clot, but it's inside of a vein. And so what happens in those cases is that you can actually then develop an extensive clot that can be even life-threatening. So that's what it means. Blood clots or venous thromboembolism, blood clots in the veins, costs about. There are about 1 million cases in the United States every year. About 10 million cases per year in the world.
Oh boy.
And
that
we don't.
Keeps you busy.
It keeps people busy for sure. But the most important thing is that about 10 to 30% of people can actually die in the first 6 months since they're diagnosed, since their diagnosis of a blood clot, which is very high chance of dying.
Yes, it is.
And then long term, about half of the patients will actually have problems as a consequence of the blood clot. We call that post-thrombotic syndrome. So syndrome or disorder after the blood clot.
Yes, okay. So you have this big
English,
glop of blood that is blocking things. Nothing can get through, or very little can get through.
That's right.
And then, so what do you do? How do you take care of that?
Well, first you need to identify, the patients.
Yes.
So
how is that done?
So it's most frequently people think, so if you develop swelling or pain, typically in the leg or legs, or in the arm or arms, that's the most typical presentation. There are other types of blood clots. They're rare. I don't want to get into that.
Right. We'll stick with the common.
The common ones are, people may develop a swelling, pain, warmth in your legs or arms. They're often associated, or often you see them when you have been immobile or not doing much for a while. Like, for example, after an operation. Or, for example, I've seen patients, that they get a gout attack, and so they're at home sitting there with their gout, relaxing, waiting for the pain to go away, and 2 or 3 days later they develop a clot, right? Or after any sort of trauma to the extremities, let's say if you're playing soccer, if you're playing football, and you get hit, and then later you develop significant swelling and pain and all that, you should suspect that. We even see it sometimes in the arms in athletes, who are really, really strong people. But most commonly it is when people all of a sudden just stop moving.
Right. Right.
If you spend a lot of time sitting down at the computer, they call that e-clotting, e-thrombosis. If people who have long travel, so if you get in a plane or in a car for a long period of time, those things predispose you to blood clots. That's kind of those are the main risk factors. There are risk factors or things that may contribute to it that are even genetic or so. I think I'm not going to get into that. And then there are well-known issues, people with cancer, people who take hormone replacement therapy, when they get to the menopause, or people who take oral contraceptives can have a higher risk of developing blood clots in the veins.
It's still, that's relatively small.
It's relatively small.
Okay. I don't want people out there worrying
Exactly.
about this.
No, it's a low risk.
Yes.
For the general population, it's a relatively small risk. If you tie that with a genetic abnormality, then the risk could go really high.
Right.
And then, so we call that venous thromboembolism, the blood clots. Now, if a blood clot, then imagine you have your entire leg filled with clot, and then all of that clot moves, and it travels to your heart, and it's going to get into the lung artery, the pulmonary artery, and it will obstruct the artery, and it can. Then now you have a clot in the lung, and so you may not be able to breathe, to exchange oxygen, and that can be sometimes fatal. Can kill people.
Yes.
And so that's why it's important. We typically diagnose this with. We look at the patient. We have to examine the patient. We have to know what the history is.
Yes.
And then we actually based the risk of the patient. Is my patient, a lot of people have swelling for many reasons.
Yes.
And they may be immobile and all these things. So we actually use the risk. And we literally use calculators and determine if the patient is a low risk or a high risk. If the patient is a high risk, we then move on directly to doing some imaging, some ultrasound studies or other tests to confirm what we suspect is a clot.
Right.
If the patient is low risk, we typically do a blood test. And we test for a substance called D-dimer. And that is a substance that is oftentimes elevated when you have a blood clot. And so if you are low risk, you may have a swollen leg, but you're low risk after we examine you, and you have a negative D-dimer, then you can, so normal D-dimer test, then you can actually say that you, confidently, that you do not have a blood clot, over 99%, about 99% accuracy.
So can you see them on ultrasound?
Yeah. So when we think that you're likely to have a clot, then we actually move on to, rather than diagnose, actually, we want to confirm our diagnosis, right? And so we do ultrasounds. You can see ultrasounds of the leg. Those are very helpful. You can see the clot. You can see how big it is, what veins are involved, and so on, and identify certain things that may put, maybe markers of a greater risk. And then in some patients, we also scan their chest with CAT scans typically, although you could do other tests. I don't want to get into the 8,000 tests that you could do. And those you can actually do to see whether you have had a clot in the lungs.
So let's say you find that. You do the test, you do an ultrasound, the blood test is positive, meaning, oh goodness, there's something going on.
If the blood test is positive, then you do an imaging test.
Yes.
So ultrasound or CAT scan.
Now what?
Yeah. Oh, now you found one.
Yeah. No. So now you got this. So now what do you do?
Yeah. Of course, it's complex. So it all depends on how the patient is doing. But the majority of the patients will require a blood thinner. The treatment for blood clots is blood thinners. There could be circumstances where a patient cannot get a blood thinner. In those cases, we sometimes put a little cage or a filter, the vena cava filter you see on TV.
Yeah.
That is usually a temporary measure to try to prevent big clots, and is usually until whatever is making you unable to receive a blood thinner, it resolves. So if we see patients, let's say they're bleeding from their stomach, and now they have a clot, you can't give them a blood thinner because they'll bleed more from the stomach.
Right.
But you could put a filter and temporize things, and then once the issue of the bleeding of the stomach has resolved, then you can put a blood thinner and take the filter out, which is really important these days.
So the filter is kind of like a strainer?
This filter is like a strainer. It's like a little metal cage that will trap most of the clots that will actually move.
But there's other, so I think, okay, I've got that in my vein. Well, where's the blood going to go? Well, you've got other veins to take care of that. But still, you'd hate
Mother Nature is very good.
Yes.
I mean, if you shut down the interstate highway, there will be exits and there will be side roads where the cars will flow.
Right.
It will be sluggish. It won't be normal.
Yep.
It'll be just like summer
scenic.
road construction, right? But eventually things move around.
Yes.
But what you want is the clot to not grow or
to stay where it is.
The blood thinners, for example, won't destroy the clot.
Yes.
The blood thinners stabilize the clot and prevent it from getting bigger, and then your own body will slowly chew it up. Okay?
Yes. It's because Mother Nature knows if it doesn't belong there, she tries to do something about it.
That's right. The important thing is, yes, there are rare circumstances where you may need to use clot-busting medicine.
Oh.
So this
Yeah.
is medicine that really
Wow.
dissolves the clot.
Yes.
But clot busting medicine is risky because
Yeah.
it can cause bleeding. you know.
Yes.
So we do that in rare cases.
Right.
It's very selective.
I'd just be kind of concerned that if you broke off a big enough piece of that clot with those clot busters, that's going to go where you don't want it to go.
Yeah, not necessarily. It typically dissolves there. It
Oh,
doesn't necessarily
okay.
increase your risk. But we use that for the people who are really
Yes.
sick.
So, so I'm just kind of getting back to the basics here. Do you have to be in the hospital to have this done?
No, I mean most tests. It depends on how you present. You could be at your primary care's office, your primary care physician's office, or the urgent care, and sometimes they can do D-dimer testing and some ultrasound if necessary. Oftentimes, patients will be diagnosed in the emergency department or other clinics. It doesn't matter. For the treatments, depends on exactly what blood thinner and exactly how you are doing as a patient.
Okay.
But these days, we have blood thinners that can be started at the time of the diagnosis as a pill form. You will be already on treatment 30 minutes later. You can go
okay.
home.
Oh, okay.
From there, which is very different compared to what it was a few years ago.
Yes.
Where you were really in the hospital for at least 5 days.
Yeah.
With an IV blood thinner, while you were then being switched over to a pill form.
Right. And they've made so much progress. That's why research is so important in everything. They've made such progress, especially with something like this.
Yeah.
So once that's done, you're home free, or not?
You're home free, yeah.
Well.
there are other treatments.
Yes.
We sometimes do procedures in selected patients, very rare circumstances. Again, it's not most patients will just get a blood thinner. But I think it's important to recognize that patients, for example, the young athletes,
Yes.
that they may need procedures, to resolve the clot and eventually to resolve issues with their muscles if they're compressing.
I was going to go back to the blood thinners. So are you on them for the rest of your life?
No. So exactly. So we sometimes do procedures. Then the blood thinners, we use them for approximately 3 to 6 months. The blanket standard is 3 months of blood thinner. At that point, it really depends on each patient. We also have multiple clinical trials that have shown, multiple studies that have shown that longer blood thinners may benefit some patients in terms of lowering the risk of another blood clot or switching to aspirin for that one matter. But it really depends on each patient and the decisions that are made together with the physician. For example, that's exactly what we do at our thrombosis center at UMass. So we see a lot of patients that were seen by different services in the hospital, or outpatients or so, and we assess them. We determine whether they need testing for genetic disorders, for example, which only a few patients would require. We determine whether the blood thinner is working well. You could be on a blood thinner, but your leg is still massively swollen. Yeah, that's not working, right? And then we need to do something about it.
Right.
And we work with the patients trying to determine what is the best approach in terms of how long the blood thinner should be. But if you ask me, what do the clinical practice guidelines say, the blanket statement is 3 months.
So what are the risks of blood thinners?
Oh, well, the main risk of blood thinners is that you can bleed.
You bleed, yes.
They
thin your blood, you're going to bleed.
Exactly. So these days, fortunately, we actually have, you worry. What if you then start bleeding from a stomach ulcer? Or what if you get involved in a car accident? And you're on a blood thinner. So those are very important questions. We always try to balance the risk and the benefit. When you have a blood clot in the leg or in the lung, you don't really have much of a choice.
Right. Right.
You ideally should be on a blood thinner. If not, it's going to progress. Right? So these days we have antidotes that can actually reverse the effects of the blood thinner for all agents right now.
Good to know.
It's really good to know. This has changed in the past year. So there were 2 medications approved by the FDA within the past year that work with 2 different types of the newer blood thinners.
Okay, great.
Yeah.
So let's move on. Now you're on your blood thinners. You offer them because it's been 3 to 6 months. And then what happens? I'm going to say the majority of the time. I know it depends on the patient.
The majority of the time, we will stop the blood thinner. We oftentimes do some testing to try to see whether the patient is at a high risk of developing a future blood clot. I think that's the main concern.
Yes.
And most patients will be placed on aspirin for life to prevent another. It decreases the risk of another clot.
So let's say they don't have risk factors. Well, they don't. They've already had one, so that increases your risk because you've already had one. But in the majority of patients, what are the long-term effects with all of this? Yeah.
So the problem is that about 50% of patients develop something called post-thrombotic syndrome.
Okay.
And so post-thrombotic syndrome is a condition in which patients may develop swelling, kind of a little bit of swelling, heaviness, skin changes, pain, achiness, etc. Sometimes it's very clear cut if the patient has had multiple clots or if there are other situations. For example, syndromes that we know where there's a compression of the veins where we can put a stent and open up, and that will decrease the problem. But there's no good way to prevent post-thrombotic syndrome. Compression stockings have been tried, medical-grade compression stockings, not the white stockings or over-the-counter. No, is prescription. Those can help at times. However, the evidence to use them routinely is confusing. Is not always. The clinical trials have not been very good at that. So yes, that's an area where patients can be left with some disability from this.
Right.
And all long-term problems. Yeah.
Is it advisable for them to do some moderate exercising, walking, or, not going out there and really booking it, but just, walk a little bit, that sort of thing? Would that be helpful?
That's a very good question. So yes, I think when a patient presents with a blood clot, we recommend that they actually walk. We don't want them exercising too much.
Right.
If you have a big clot, but we want you to walk around, and so days later we would encourage you to try to get back to your normal. If someone is an active person, back to their normal activities. But yes, the point is that we want to discourage people just staying in bed because what if the clot moves?
Right.
No, that's actually worse.
Yes.
And we want people moving, walking. It's very interesting. The veins drain blood. They have little valves that kind of help, like gates. Almost like the Panama Canal.
Yes.
Different gates that help the blood move forward, but also the muscles. And this is where the walking comes in handy. The muscle function squeezes those veins and helps the fluid kind of get back to what it needs to be.
So I just had a visual of sitting on a plane, and it's a long flight, and you watch people, flexing their legs up and down, trying to get their calf muscles to get a little exercise.
Exactly. So getting up. Some people wear stockings, but it's essentially exercises where you move your leg, trying to walk around, up and down the plane.
Yes.
Those are the things that are very important. Avoiding dehydration.
Yes.
We haven't talked about a very important risk factor for the initial clot or recurrent clots, and that's smoking. Smoking is bad.
It's bad for everything, that's for sure.
It's bad for everything. But smoking, of course, increases the risk of blood clots.
Yes. And it also increases your risk for many other things, but the
blood clots in particular. Do they know why? I mean, I understand that smoking's bad, but in particular for this, is there something in them? Is it the nicotine? Is it the tar? Is it?
I don't know that we know the answer exactly. It is a combination of things. The chemicals that go is not only the nicotine. There are thousands of chemicals in the cigarette smoke.
Yes.
I suspect this could be a problem with other forms of inhaled substances, like smoked marijuana, whereas the combustion, the actual burning of something and inhaling the smoke can actually cause problems.
Right.
We see that in people who we see problems in heart, lungs, or so in other conditions. Like for example, people who cook with wooden stoves, in third world countries.
Yes.
Their huts are all filled with smoke, and they develop long-term problems. We see that. We've seen cases of some artery issues or so in people with who use marijuana. So we don't know, what will happen with the legalization of marijuana, but I would expect that will be probably another factor. It has to do with the smoke and the
Right. And
burning.
I'm also concerned as far as e-cigarettes, that sort of thing, because those are combustible, they're smoke.
Yes.
So
we know that these substances, there was a recent clinical study published linking e-cigarettes also with inflammation in the blood vessels.
yes,
Almost as bad as the cigarette.
A regular cigarette,
Yeah.
right.
So
So you're going to find this very hard to believe. We have 2 minutes left.
we do.
Yes, we do.
Okay.
So can you tell us, we have 1 minute left now almost.
All right.
Can you tell us a little bit, if you wanted to say a few words about just to let people take home message with this, what would they be?
Yeah. I think it's important for people to recognize, to know that if they've developed severe swelling, leg pain, redness in their arms or the legs, or if they develop sudden shortness of breath, they should not ignore it. They should seek medical care.
Yes.
That there could be a blood clot. The blood clots are treated with blood thinners typically, and then there are many different components of it.
Thank you very, very much. This has been very
Thank you.
interesting. I hope, I'm glad you were able to join us, and thank you very much. Again, this is Health Matters from the Worcester District Medical Society. I'm Dr. Lynda Young. Thank you for watching.
Yeah.